We can make a start. So we've just had our talk from Syrian, and our second speaker today is Professor Michael Parker. Professor Michael Parker is a professor of bioethics at the University of Oxford, leading a program of cross-disciplinary research focused on ethical problems presented by genomics, data science, and global health. His work involves collaborating with world-renowned institutions, including the Malaria Genomics Epidemiology Network, the Wellcome Africa and Asia Programme, the Oxford Big Data Institute, UK Biobank, and the 100,000 Genome Project. Professor Parker is also a member of the British Government's Scientific Advisory Group for Emergencies, and we are privileged to have him address our audience today on the topic of ethics in medical research. So I'll hand the floor over to you, Professor Parker.
Brilliant. Thanks very much, Aisha. And first of all, just want to say thank you very much for inviting me to do this. It's a great pleasure to be here. I've already learned something. So Ian, thank you very much for the book recommendation. I'll be ordering that later. Sounds great. One of the things about those kind of introductions, which is it's nice to be introduced in a nice way, but also it kind of makes it sound a bit more formal, maybe. So first of all, just call me Mike if you have a question, whatever. But also, I quite like to have a interactive discussion if at all possible. I realize there are a lot of you on there, and it's not being online is not perfect for that. But if you do have a question, or if you want to interrupt in some way, if there's something I've said that's not clear enough, please just chip in. I'm not sure, when I switch to full screen, I'm not sure whether I'll be able to see the chat, so I'll try to look at it, but if not, then you might just have to speak out. I've got a few cases in here that be great to hear your views on. Yeah, as I say, I'll just talk, but please do interrupt me. Lots of people say that. I really mean it, so please do. Yeah, my name's Mike Parker. I'm, as Aisha said, I'm the director of a centre in Oxford called the Ethox Centre. I've got sort of two main areas of interest myself, and there are about 55 people, I think, in the centre. My two main areas of interest. One is in global health, ethical issues in large-scale global health research projects. So I'm interested I work with partners in Africa and Southeast Asia, but also many other parts of the world, to think about the sort of ethics of questions arising, for example, in research on infectious diseases, that kind of thing. And the other area of interest is in the ethical issues arising in genomic research of various kinds, genomic and data-driven research. And if there's time at the end, I'm happy to say more about those. I think my talk leads on quite nicely from Ian's, because he's called for evidence-based medicine and a real focus on on research. So I'm going to say something about the ethical aspects of research involving human participants. So I'll switch to full screen now, and hopefully you can see all that. Let me just move this to the screen so I can actually see what I'm talking about. Yeah, okay, so that's the focus, the ethics of research involving human participants. One of the first questions, I suppose, is what is ethics? What is research ethics? And I think that when people come to this topic, I think there are a number of ways in which they come to it. So some people will think about research ethics as the kind of process you have to go through if you're a medical researcher or researcher of other kinds. There's a whole lot of processes, research ethics committees and so on, and the research ethics is that. So for some people, it's that. For others, the thing that will come to mind are these large, important international guidelines and declarations of various kinds. And the obvious one that most people will think of is the Declaration of Helsinki, which has been iterated many times since it was first written by the World Medical Association in the early 60s, 1964, I think. Or, for example, the Belmont Report, which was an American guideline, which really kind of was the first guideline to establish these what have come to be known as sort of the principles of medical ethics. So these kind of founding documents is another way in which people sometimes think about research ethics. For others, it will be about high-profile occasions when research appears to have gone wrong. It appears to be doing things that are either scandalous in some way or otherwise just seem to be inappropriate. And there's always plenty of discussion of these kind of issues in the media. And here are a couple of examples. One on the right is a drug study in France where a research participant died. Another is Facebook research reading emotions of people using online social media and so on. So situations like this where questions get presented about, well, is this research ethical or is it not? And all of those things are clearly related and relevant to what research ethics is. And I'll sort of refer to them a bit as I go through. But what I want to do in a way is to think about it in a way that's more closely related to day-to-day work, but also I think is able to help. The idea is to help you to think through some of the ethical issues that might arise in the research that you get either involved in yourself as a researcher, or perhaps the kind of research that someone approaches you about to do research with your patients. So I'll sort of go through a number of things here. One distinction that I think is probably quite important to make early on is the distinction between what I've called here ground level thinking about ethics. And these are questions like, for example, how confident am I in this particular situation that the people who have been invited to take part in this study properly understand what it is that they are signing up to and they're happy with it, and they've done that in a voluntary way. So has consent been properly obtained on this particular occasion, or perhaps across the study as a whole? And as an important subset of that, of the things that need to get talked about at consent, are these questions about risks and benefits. So have those been, first of all, are they properly understood, and secondly, have they been clearly described to potential participants, and have they understood them? So those kind of ground level ethical questions that arise in the sort of day-to-day research conduct of doing medical research. And then there are some broader questions about, for example, clinical trials. So some of these will relate to the question, well, should this trial actually be taking place at all? Is doing this kind of thing ethical? And then there are questions to do with, well, if it should be done, should it be done in this particular way? So is the trial justified in the way it's proposed? So these are bigger questions about the nature of research, the ethics of research, and whether it should be done and how it should be done. And I want to start off by, I want to say something first of all about ethics and science before I want to give you a case to begin with. But one of the things I think it's important to say, as I said at the beginning, with these tick boxes, scientists and doctors and nurses and so on will often have experienced ethics as being about oversight, guidelines. And so those guidelines will often be perceived as hurdles to doing important things. And they can sometimes be seen as in opposition to medical research, the kind of things that Ian was talking about earlier. But of course, it's really important not to see ethics in that narrow way. Ian made the case much more articulately than I will, but it's pretty clear, I think, without too much thought, that medical science, saving lives, reducing suffering, improving the quality of lives, is clearly of hugely important moral significance. And that means there are strong ethical arguments in favor of doing research, obviously, when that research is ethically conducted. So we shouldn't start from the point of view of thinking medical research is unethical unless certain criteria are met. We should be thinking actually the generation of knowledge relating to medicine and improving the quality of people's lives is a morally good thing. And that's increasingly being seen, I think. So, for example, it wasn't that long ago that it was very common, for example, to exclude pregnant women or children from research on the grounds that these were groups that needed to be protected because they were vulnerable. And in the last decade or so, there's been a shift towards the idea that actually sometimes, rather than protecting people from research, you can protect them through research. And so there's been a growth in the amount of research that's done with pregnant women or with children as a result of that recognition that medical research actually is of moral value. So I just want to sort of separate slightly these two different ways of thinking about ethics. So what I'm going to do now is introduce a case which I think is quite interesting and raises some of these issues. Talk a little bit about the relationships between what ethics means in research for doctors and for medical researchers. talk about a bit about the relationship between, or the tension sometimes between, research ethics and clinical ethics. And then what I'm going to do is go through a number of cases just to sort of sketch out some ways of thinking about some principles of research ethics. A little bit of practical stuff then about, well, what to think about if you're doing a research project. And then I've got some more cases at the end if we have time. But I'm kind of hoping in a way that you'll interject and I won't get to those cases at the end, but let's see. Okay, so I want to start off by introducing this case. So this is a case of a study in emergency medicine, and there's a link at the bottom there if you want to look at the study, but don't do that now. So the study starts from the question: well, if someone has a heart attack, should adrenaline be before I describe it, I should say I'm not a doctor, so if I don't express medical points clearly, then forgive me for that. My background's in ethics. So the question here is should adrenaline be used when someone's heart stops? The standard of care, that's the standard of care, but there's some evidence that it's either ineffective or it's harmful, and there appears to be some genuine uncertainty about that. So in the late sort of 2018, 2019, a study involving, I think it was Warwick University and Oxford University, decided it would recruit 8,000 patients and it would randomize them between, so these are people who are having heart attacks, between a shot of adrenaline, which is the standard practice, and a placebo. And as you can imagine, this study raised a number of ethical questions for people. So as you see on the right hand side, that newspaper headline is "Heart Patients to be Given a Placebo by Paramedics in Controversial Trial." So this idea, this trial was controversial, and that number of articles were published arguing in favor or against the study. So, the paper in the BMJ says adrenaline in cardiac arrest, it's unethical for patients not to know. And then the paper on the left says this hugely important study has come in for hostile criticism from some ethicists. The only ethical problem I've had with this trial is that it wasn't done years ago. So really interesting. Seems like an important study, but has created lots of controversy. So imagine that you're sitting on the ethics committee and you've been given this job of evaluating the ethics of this research, re-evaluating midway through the trial. So you're halfway through and you're being asked, should this research be defended or not? So should it be allowed to continue or not? So if you were in a room, I would be asking you and picking on people and saying, tell me what you think about this. Does anyone want to express a view on this? What do you think?
Well, I carry around a card in my wallet which says, in circumstances where there's uncertainty about what to do, randomize me.
Great, thanks. Right, so we're getting a few well, at least. So Peter, you said it. You don't think it shouldn't. You say it shouldn't go through. Do you want to either in the chat or in or by speaking on the microphone? Why don't you think it should go through?
We've got somebody else who's raised their hand.
Okay, I can't see those. So yeah, please do speak up.
Mara, if you want to say what you want to.
Yes, please.
Okay, great.
Okay, I think it's unethical as we are putting someone's life in danger. We know that we're using adrenal when someone's life is in danger, and if we use placebo, we might have the chance to lose him. And placebo should have no danger on someone's life. And when we use placebo, we are putting his life in danger as he might die because of our mistake. So I think this study shouldn't go or shouldn't continue. That's my point of view.
Thanks very much. Well, obviously it's clearly the amount of risk associated with the study needs to be carefully thought about, doesn't it? Because there are all sorts of possible studies that can be imagined that might be unacceptable because of the level of risk. That's not obviously not to say that no risk is acceptable, and I'll come to that in a moment. But you're right to say that is this randomization harmful or not? One of the well, let's see what I'll get your name pronounce it wrong. Moaid. Do you want to say what your thoughts?
Hi, thank you.
Yeah.
Well, my thoughts are I'm pro placebo. because despite the fact that it may be unethical if the medication was useful, I remember watching an episode of House where there was one of the main characters had Parkinson's, and they tried to give her this experimental treatment until the person who was administering it thought that it was a double-blinded test, by the way.
Yeah.
And he realized, and the person was his lover, and so he realized that it was a placebo, and then he changed the subjects, and he gave her the actual treatment, which was unethical because he shouldn't know what the treatment is. And when he gave it to her, she had severe side effects that were just mainly harmful. So I think a placebo is just a double-edged sword. You can either, the person taking it could either avoid the harmful side effects, or they could be prevented from taking a useful medication. And so I think it just goes both ways. And placebos are useful in general because you don't want to, like the brain to influence the results with personal bias and whatnot. So a placebo is good for control, I think.
Great. Okay. Thank you very much. That's really interesting. Both those perspectives are really interesting. I mean, one of the things that seems important here, I'll move on in a minute. One of the things that seems important is just this question of how uncertain we are about whether this actually does any good or not. Because, Mara's point, if we knew that adrenaline was the thing that saved people's lives here, then of course we wouldn't be randomizing people, or we shouldn't be randomizing. But if, as the proponents of the study argue, it could just be as well that it could be just as likely that it's causing harm rather than in benefiting in this situation, then it seems like there's a good case for doing the research. But anyway, let's move on. We'll come back to that. So how might we solve this? So one way we might solve it is something along the lines that sort of Ian outlined here, really, which is we might develop a solution which is sort of an opt-out consent. We might develop some kind of way in the study area that people can indicate that they don't want to be part of this study. So then they would get the standard of care, which would be adrenaline. So one of the things that was proposed in this study was this idea of a bracelet that people could wear, which indicated that they didn't want to be part of the study, and they would be notified at the end of the study that they didn't need to wear the bracelet anymore. And you can imagine there are a number of ways in which that might be valuable. It's a way for people to express their views, but of course there are a number of ways in which it might fail, because of course there might be people out there who wouldn't want to be involved in the study, who never heard about this option. So it's not going to be a perfect model. Another way forward might be just to make the case for the social value of this research. It resolves this uncertainty. If it's genuinely true that we don't know whether this adrenaline does any good or not, there seems huge social value in clarifying that situation. Okay, so that's just a case to get us started. Maybe we'll return to that later. But of course, there are a number of questions that come out of this. So one is, under what kind of conditions in a research project is it ethical not to use what's currently known as the standard of care in this particular situation? When, if ever, is a placebo-controlled study ethically permissible? When, if ever, is research ethical in the absence of informed consent? Is consent the measure of ethics of research, or are there other situations in which it might be acceptable to do research without consent? And we can talk about, there are lots of examples of situations where people might think that was appropriate. And then this question about, well, are there special ethical problems generated by when you're doing research with a group that is particularly vulnerable or particularly sick? In this case, people in having heart attacks. Okay, so let's step back a little bit and think about what's the, sorry, I'm getting stuck here. Let's think about how we should think about research. So when we're thinking about research, what is it? Two elements seem important. One is that it's an investigation that's systematic and structured, has some aims and so on. And secondly, that its aim is to generate generalizable knowledge. So the aim is to learn things from this study which can be applicable elsewhere. And this creates some interesting tensions or differences between the ethics of day-to-day medicine and the ethics of research. So if you think about the kinds of ethical issues that arise in day-to-day medicine, they're often to do with what is in the best interest of this patient, or what does this patient want, or sometimes tensions between those two. So, you've got a patient that wants a treatment or doesn't want a treatment that you think isn't in their best interest. So how do you manage those kinds of tensions? Those are the sorts of things that arise in clinical ethics, or sometimes tensions relating to resource allocation. There's not enough medicine to go around. How do we decide which patient should be treated first? On the other hand, in research ethics, what we're talking about here is there's a tensions between, on the one hand, the interests of this individual patient or participant, and those of medical science or future people in the future. So there's quite different tensions arising. There's ethics in both places, but they take a different form. And this also suggests that ethical issues arise both for medical researchers and for clinicians. So for medical researchers, and obviously it's important to note that some people are both doctors and medical researchers, or nurses and medical researchers, but as medical researchers, the questions that arise for people relating to ethics in those roles are questions about the design and conduct of the study, questions relating to ethical review. Whereas for doctors, a whole range of other questions arise, like, for example, how do we advise patients who say to us that I'm thinking about joining a research study? How should we think about having that conversation, particularly if we've got strong views about, for example, the benefits of research? How do we make sure we have that conversation in a way that's appropriate? How do we deal with situations where, on the one hand, we're treating patients, on the other hand, we've been asked to play a part in recruiting patients to research studies? How do we think about that? How do we think about incentives for research? And how do we think about research that's actually on medical practice, research that's about the practice of doctors and the health system itself? So ethical issues relating to research ethics are not just problems for medical researchers, they're also problems for other people. And if there's an interesting ethical challenge arises here, because if you're a doctor, historically, and in your training and so on, the idea here is that you're supposed to focus on the benefit of your particular patient. When you're caring for the patient, that patient should be your primary concern, your duty of care to them, protect and promote. But the problem with medical research is that it's not uniquely in the interest of these particular patients in front of you. So there are issues to do, as we've heard, to do with randomization, blinding, etc., which require doctors to think carefully in these conversations about, well, how do I balance, for example, the interests of my particular patient, protecting the health of my patient, whilst at the same time having a conversation with them about participating in research to benefit other people. So this is to some extent a challenge within the context of the role of the medical doctor. So the question it raises is how can a physician fulfill, on the one hand, their obligations to patients in front of them, on the other hand, recommend that they participate in trials? And there have been some people, and this is a paper in the 1990s, who said it was unmanageable. You just can't. Unacceptable for doctors to recommend their patients participate in trials. It was an unacceptable violation of patient rights. They sacrificed through their entitlement to individualized cares, and this person recommended that they should abandon all medical trials. So clearly, I'm assuming most of you on this call think that can't be right. So we have to sort of find some way of developing a way of understanding the physician's role, which is both patient-centered, appropriately focused on the patient's needs, but nonetheless pursues the generation of medical knowledge. So it raises important issues, I think, about the role of medicine. And the question here is, well, what exactly is it that justifies exposing patients to risk for the benefit of other people? And there are a number of possibilities here. So one would be, we get their permission, we ask them. So consent is what makes it acceptable to expose people to risk for the benefits of other people. And then, but this raises all sorts of questions like, well, is consent always necessary? It raises questions, well, is consent getting enough? Is consent sufficient? So if a patient fully autonomously and in full understanding consents to be involved in a very, very risky medical research project, is consent enough, or do we have other obligations, for example, to minimize risks and so on? is it possible, and if so, under what kind of circumstances is it possible for that someone might consent for someone else to be involved in a research project? So a whole range of questions about consent, but also some limits about the role of consent in giving permission for exposing people to risk. So another question might be, well, as I just alluded to, well, let's beyond consent, what else might be needed? Well, another one might be if appropriate limits are placed on the risks. So, we might say subjecting someone to risks for the benefit of others is okay if the risks are minimal. So that raises all sorts of questions. Well, how do we decide when risks are reasonable, and how do we judge that against the possible benefits of the knowledge to be gained? How do we think about that? Secondly, there are questions about measuring risk. Well, how do we go about quantifying the risk? How big is the risk and how likely is the risk to happen? And then a sort of broader philosophical question to some extent, which should there be an upper limit on risk? So the Nuremberg Code, for example, said, I'm paraphrasing, said it was unacceptable for someone in a research project to be exposed to a risk of death. And it had the caveat was this is a case where a medical researcher or a medical doctor is doing research on themselves. So they took the view risk of death was a kind of absolute limit. But what do we think? Should it be lower than that? Are there other limits? And then a third possibility would be, well, exposing people to risk is, there are sort of fairness considerations here. And the question then is, well, who should participate in the research and why? How do we distribute the benefits of research fairly? And should we be excluding certain populations from research? And I'll say something about these later. But these are a number of questions that it seems important to ask when research is ultimately about when is it reasonable to expose someone to some level of risk in the pursuit of knowledge. Okay, so let me give you another case. So Jones is a 60-year-old patient in the early stages of Alzheimer's and has been invited to participate in a study examining a new drug to help limit memory loss. The study is going to randomize subjects to an experimental arm in which they will receive the new drug, or a control arm with careful monitoring. Now, you were present when the researcher got informed consent from Jones, and that was 3 days ago. And it's your job to discuss any questions or concern the participant has, and report back to the PI about any concerns or problems. So when you visit Jones on the day of the study, he remembers you and he remembers signing the consent document. And with confidence, he tells you he's really excited to participate in the study because the study aims to limit his memory loss. So the question is, what under these circumstances should you tell the PI? Wonder what you think about that. Maybe just, and does anyone have any thoughts about this? So what's the issue here? Yeah, Maid.
I have a question about the whole Alzheimer's deal.
Yeah.
So what if he forgets that he gave consent and then just suddenly kind of popped out, just like was like, wait a minute, what am I doing here? What are we doing? I don't want to be part of this anymore. And like, let's say you're you're halfway through the experiment. I don't know, what would the protocol be here if he just forgets about it all?
Yeah. So, okay, so that raises a number of questions, doesn't it? So it raises some deep philosophical questions about, how do you deal with situations where someone, when they are fully competent, makes a choice which affects them, and then later loses their capacity. So how do you deal with that change, and do you respect the old voice, or do you respect the new voice, as it were? So someone who accepts a treatment before they lose capacity and then seems to be rejecting it later. So that's a really interesting question there. There are also questions about how you might design a study. Presumably I'm assuming there are studies where the whole point in some ways is to study loss of capacity to some extent. So the question then is, well, what kind of consent would be appropriate in that kind of study? And how would you deal with exactly the kind of situation you described, where someone appears either distressed by the study or appears to have changed their mind. In the UK, I'm not sure about your setting, but in the UK, for example, if a patient, a research participant without capacity is distressed in any way, or in these but then the study would be excluded from the study. So there's a Mental Capacity Act which would stop you doing that, I think. But the question here, so I think there's a lot of issues, and given limited time, I'll probably off into too many philosophical reveries at this point. But the point here is, this person appears to have misunderstood the purpose of the study, doesn't he? So the study is randomizing people to understand whether this drug limits memory loss. This participant appears to believe that this study is going to limit his memory loss. So there's an important question there about to what extent has he understood the randomization, and to what extent has he really understood that this is a research project. So it raises quite important questions about consent. So thinking about it very practically, this is not in any way to say that your question, your reply is not unimportant. It's actually really, really interesting, and I'd love to spend another hour talking about that, if I'm honest. So the question is, you're running a research study, and you find out that people are not fully understanding the nature of the project. They've got a misunderstanding about the project. How do you deal with that? And it raises some important points about consent, doesn't it? So there's a few things to say about consent. I mean, in most areas of research, informed consent is a necessary requirement. There are some exceptions, and we can talk a bit about those. But what does consent mean in a research study? What does valid consent mean in a research study? Generally speaking, it's understood to include these three elements. So on the one hand, this is information, voluntariness, and competence. So if you're observing, imagine you were watching a consent process you're observing someone else take consent. There are three ways in which it could go wrong. The first would be the person either hasn't been given all of the information that they need to know in order to decide whether to participate or not, or secondly, they haven't understood it. So there's a range of reasons related to information. And then there are important questions which we can't perhaps go into here, which is, well, how much information does someone need? Perfect understanding of research can't be a reasonable standard, because many researchers don't fully understand all of the aspects of the research they're involved in. So what's an appropriate level of understanding is a really important question. Secondly, voluntariness. Is the person making a choice a free choice, or are there pressures on them that make the choice one in which they would have chosen otherwise under other circumstances?
We have a question on that.
Yeah, sure. Yeah, sure. Let me just say about competence, and then I'll come back to you. Okay. So, and the third element is competence. To what extent is this person competent to make this choice? So this is sort of these are the three elements that we normally think about when we're thinking about consent, either in clinical practice or in research. Yeah, go. What's your question?
So you talked about pressures and things, outside factors that might influence this person to choose this research that he might not, or they might not have chosen it otherwise. Yeah. What about a research that is funded, where they give volunteers money? And let's say the person was poor, and I've watched movies about that, where some people just like go and try to make, and documentaries as well, where people just participate in many clinical trials just to gain some funds that they're pressured by their socioeconomic situations. And that kind of raised some ethical questions in my mind. Like, if you're rich, then you probably wouldn't enroll yourself in such risky studies. But if you're poor and there is like some good pay, you might consider it.
Yeah. So I think that raises a number of important questions too. So one approach that could be taken in the context of research is that research should be fully altruistic. So people should do it purely because they want to support the generation of knowledge that will save lives and improve quality of lives, reduce suffering, and so on. And there should be no benefits involved whatsoever. And there used to be a strong view that was the way to think about medical research. But then in a number of situations that seems problematic. So one example would be a lot of the research that I'm involved in, for example, is in very poor settings. So research that's undertaken in very poor regions in Malawi or Kenya, and people are having to walk a long way to get to the research center. Maybe they're subsistence farmers and they're giving up a day's work on the land, and so there's a whole range of reasons why people have started to say, well, at the very least, you should be compensating people for the losses entailed in that they accrue as a result of participating in research. So that seems like a reasonable argument in a way to say that compensation should be part of it. But it does raise these questions then about, well, to what extent is informed consent free and voluntary? So a good example might be in those kind of situations, you might start to hear that some of the people are participating because they get a day off the farm, for example. They get a day off of not without working on the farm, or they get a lunch at the hospital. They come to do the research. And I think there's not really a simple answer to this, because what that suggests is there are ethical arguments around consent that we need to take very seriously. Consent needs to be good consent. On the other hand, ethical considerations about what our responsibilities are for example, in that kind of situation, which is a poor setting, it seems reasonable that people ought to be compensated in some way. So that's one sort of way in which that question about compensation has been problematized. But actually, it's also even in richer settings, that it's become the question of compensation. So people are generally not paid to participate in research. What they do get, though, is compensation of some sort. I've just described what it looks like in the poor setting, but say, for example, medical students in Oxford who are participating in malaria challenge studies, for example. So this involves them being given malaria, an attenuated form of malaria, and then they're treated. And students will normally be paid, £2,000 or something, or possibly more, to go through this study. And that's partly because they could be sick, partly because they would be, taking time off their studies or whatever. And so the world has changed a little bit, I think. So I think what that suggests is that there are some times when it's right to provide some compensation. But your question is absolutely right too, which is, well, that doesn't mean anything goes. So, if it becomes, there must be some limit to that, because, as you say, you've got someone who's very disadvantaged. You give them a lot of money, and they participate in some activity that they wouldn't otherwise do. They're going against their better judgment. So this is quite a lively debate in research ethics. So I can recommend papers to you, but there's a lively debate about them at the moment about benefits and their implications for the ethics of research studies. So you're right to raise that. You're right to raise that issue. Okay, one thing I wanted to raise, though, in that situation is this point about what's sometimes called the therapeutic misconception, something that Jones seems to be susceptible to in that previous example. So he's someone who is conflating research with care. So he thinks he's been recruited into a research study where the medical benefits are unclear. There's genuine uncertainty about which of these courses of action is best to use. But he thinks he's taking part in this study because he's getting better care as a result. And this raises the therapeutic misconception is very common. Lots of social science has been done on research participants' understanding of participation in research, and it's very common for people to believe that they're going to get some clinical benefit from participation. So the question then is, well, to what extent? Clearly, you should try as a researcher to minimize that, but does the very fact of it invalidate informed consent? So we then get these questions about informed consent and its limits and how we understand that. It's important to make a bit of some distinctions here, though. So there are various ways in which someone might be mistaken when they make that choice to participate in research in this way. So one is the therapeutic misconception, which I've just described. Someone thinks this is care when in fact it's research. Another is a sort of what's sometimes called therapeutic misestimation, which is they've kind of miscalculated the risks and benefits. So they've got making an erroneous judgment of some sort. And the third is someone who's just very optimistic. Yes, this is clearly going to benefit me, and is taking part on the grounds of an unjustified optimism about the study. So, you know, what should we do in the case of Jones? How should we decide whether he should participate? So there are a number of things we might want to think about. One might be, does he really understand that this is a randomized trial? Can we help him to understand that? Does he understand, the probability that he's going to be in one arm or another? Is he competent? A range of questions that we need to ask in the context of this kind of study, and probably many other kinds of studies too. So there's a range of questions here related to risk and informed consent. Okay, so I want to move on to give you another case now. So this is a case of a doctor who's Dr. Malone. So she's a primary care doctor, and she's working at a large research institution. One of her patients, who's called Charlie, is 20 years old, and he's just been diagnosed with stage 4 lung cancer. The 5-year observed survival rate is 1%, and the current standard of care is chemotherapy. The FDA has just approved a promising new drug called MX320 for clinical trials, and a medical school classmate of Dr. Malone's is the primary investigator for an active controlled double-blind randomized controlled trial. Early phase investigations suggest that patients receiving the new drug are improving. And based on this promising information, Dr. Malone thinks Charlie would probably be a good candidate for the drug. There's no guarantee that Charlie would be randomized to the experimental arm of the trial, but Dr. Malone and Charlie are hopeful. So Charlie enrolls. After some weeks, he's showing no improvement, and Dr. Malone begins to wonder whether he was in fact randomized to the control treatment arm. So this comes back to the example from the movie that you talked about. Dr. Malone feels responsible for possibly giving his patient her patient false hope. She's aware of another clinical trial from which Charlie might benefit, and is unsure whether she should voice her suspicions to Charlie. But if she does that, he might leave this study and go to the other study, or should she keep her concerns to herself? And one of the questions here, again, as in the very first study, is, how should we think about uncertainty in this kind of context? How should we think about what's often referred to as the equipoise here? There are a number of different ways of thinking about equipoise. So this is the idea of uncertainty, about genuine uncertainty about the effectiveness of the interventions in the different arms. And there are a number of ways of thinking about it, but possibly the most plausible of these is the idea of clinical equipoise. So this is a situation in which there's a state of honest professional disagreement among the community of experts about the merits of these two different treatment options. So the question about what's the difference between uncertainty or disagreement, and there's a question about, who should be uncertain and how uncertain they should be. But this was one way of thinking about whether a study is acceptable or not, has an acceptable level of uncertainty or not. So the argument here is that it's permissible to recommend that someone enrolls or is randomized as long as the evidence is unclear, as long as there's genuine disagreement about which arm of the trial is better. So if this is a situation, then you as a researcher or doctor, you're not violating any duty to the patient because there's genuine uncertainty. And you can recommend they participate, even if you personally prefer drug A to drug B. You can still, because there's genuine community uncertainty, you can recommend that the patient participates in this. And there are a number of things we might want to think about here. Just in the interest of time, I'll probably move on, I think, from here. But thinking about this case, what does it mean? Well, one way of thinking about it was, are the different arms of this trial, the trial that Charlie is being recruited in, are they both consistent with medical care? And if they are, then the fact that the patient isn't immediately benefiting is not necessarily a sign of being disadvantaged, because we don't know. That's why the research is being done.
May I ask a question? Really quickly?
Yeah, sure.
Well, I know that giving placebo and having a case branch in a research is quite beneficial. But I was wondering whether it should always be the case, especially when it's like a life or death thing, and where the person is already in lost hope, like stage 4 lung cancer, where the survival rate is just less than 1%. And the person is about to die anyways, and they are ready to take all the chances. And like, why can't they all just run on the experimental branch, even despite the fact that there might be some bad side effects, or they might even die from the medication? For them, I would think that they have already kind of accepted that, since they were really dying anyways. And if they kind of give their consent to just go on the experimental branch right away, I don't see what the use of a placebo branch would do, other than maybe give a little more accurate information for the researchers themselves. But I think, well, I don't know whether it would be more significant than just giving everybody the treatment and giving them whatever, and bumping up their chances with whatever it may be percentage.
Yeah, well, my understanding of this, and not being an expert, is that it wasn't a placebo-controlled trial. It was a trial where they're being randomized to two different standard treatment versus this other thing. But yeah, so there are important questions, aren't there, about whether the ethics of research are different in situations where there are no other alternatives available. So, one of the ways in which it might be different, for example, is that if all available evidence-based interventions have been exhausted and the patient's not improved and, as you say, getting near the end of their life, but wants nonetheless an intervention, you might say in that kind of situation that you might be willing to allow, on ethical grounds, a higher level of risk. So you might, for example, in that sort of situation, say that an innovative drug with less than perfect evidence might be appropriate to do as long as it was done as part of a study of some kind. It might be appropriate because there are no other options available for that person. But the point you're raising, I suppose, is to some extent, to what extent is the ethics of research different in situations where there are no other treatments available? And I think that's an important point. And the key thing here is, when you're going to an ethics committee to get ethics approval for a study, you need to be able to just provide a justification for why this research is appropriate for this particular population. The point about this section, though, is just, in a way, is to think about this question of equipoise. There's a whole range of reasons, or when it's appropriate to recruit someone into study, what counts as genuine uncertainty between these two treatments, and the existence of clinical equipoise provides some justification for there being some hope that this intervention might produce some benefits and might generate knowledge. So equipoise is another area. So what you see I'm doing here, I'm obviously not answering all of these questions. What I'm trying to do is map out areas of ethical significance in the conduct of research. And obviously I'm happy to provide other additional readings if you're interested. Okay, let me give you another case. So this is Professor Smith is a leading stroke specialist, and she's thinking of developing a randomized control trial examining the benefits of a common analgesic to be given to patients after having had a stroke. She strongly believes that the drug will have a major impact on recovery rates, and she proposes that the trial recruits male subjects from 3 larger urban hospitals in Uganda. When you ask her about why she decided to conduct the research in Uganda, she answers that in her experience, subject recruitment is much faster there than in the UK. This means that any beneficial results, because recruitment's faster, that means the results will come in faster, and that means that if this does lead to a better treatment, people will get it sooner. So the question this raises is, well, is this research permissible or isn't it? And there are a number of questions you might want to ask about this. So some of them are to do with, is the selection of research participants fair? So, it sounds from this researcher that she's chosen Uganda not because this is a place where the research is particularly relevant to the population in that urban area, but because it's a convenient population where the research recruitment is going to be faster than in other places. So to what extent does that mean that this is unethical? To what extent does it mean, well, there might be other reasons for thinking this is an appropriate place, but it's certainly something that requires justification. So if you look at the guidelines, for example, the Helsinki declarations, one of the things they are most worried about is the idea that people will do researchers will do research in settings for reasons other than research benefit. They will do, for example, many studies being done as here in low-income settings because there are less regulations, fewer regulations, or your recruitment is easier. So, a number of questions to ask here is, the point about the population being just a population of convenience, but also these questions about, well, how might we think about the responsibilities of researchers to these communities? And this raises the question of compensation, which was raised earlier. So in this particular case, we might say, well, to what extent are strokes a health concern in this host country, in Uganda? Well, clearly they will be a concern to some extent, but how much of a priority are strokes compared, for example, to other kinds of research that might be done? Are there any plans? Does the research have any plans to try to make it possible for the analgesic to be made available in Uganda, or is this one of those studies that's going to benefit patients mostly in rich countries? So then there's a number of questions about what justifies exposing subjects to risk for other people, and we've some new questions, some questions which are similar, informed consent questions, some about balancing harms, and some about fair options. So who should be participating in this research, and why should this research be done in Uganda, or shouldn't it? How should we distribute the benefits and burdens of research? What does it mean to do that fairly, and so on. So there's a number of, I think, ethical principles and kind of moral rules. It might be just sort of pulling some of that together. It might be worth thinking about. So on the left, I've got sort of 3 common moral principles that are usually called upon in the context of research ethics, and these have become central over the time. They were really, the Belmont report, which I highlighted at the beginning, was, I think, the first report to sort of systematically say this is the way we're going to organize thinking about the ethics of medical research. But they seem like sensible moral principles to start with. So respect for persons. What does that mean in this particular situation? What it really means is, taking people seriously, valuing people equally, and recognizing that they ought to be able to make decisions about their own lives based on their own values. And in the context of medical research, this means, for example, making sure that as much as possible and where possible, you obtain valid consent from prospective research participants. But it also has broader implications too. For example, it might be important. An important element of respect for persons might be that their confidentiality is protected. For example, information about their health status is not made publicly available. And to some extent, these respect for person questions are going to be culturally specific. So, you can probably think of examples from your own setting where there'll be particular things that will be right to do to respect research participants if you're inviting them to be involved in the study. So a whole lot of stuff to do with consent, but broader than that too. Second principle, beneficence. So this is the idea that research ought to be benefiting people of some sort. So a focus on benefits and harms. So here, therapeutic procedures must be consistent with competent medical care. So incompetence is not acceptable. Risks of non-therapeutic procedures. So the risks of, so where you've got therapeutic research, for example, it should be competent. If you're doing non-therapeutic procedures as part of a research study, then the risks should be minimized, and they should be reasonable in relation to the knowledge to be gained. And then finally, justice. So justice here is the concept that is related or raised to some of the issues that were in that last case. So is the selection of subjects fair? Is the selection of research topics fair? So, for example, there's been a debate for many years about why it is that medical research pays a much greater proportion of its attention and its resources to problems affecting people living in rich countries. So there used to be this thing called the 90-10 gap, which is 90% of the world's medical research resources are used to investigate the problems affecting 10% of the world's population. So is the research prioritization itself fair? And then, questions relating to, well, what should you do if someone is harmed as a result of research? So what might be an appropriate kind of compensation for someone in that situation? Okay, so what I've tried to do there is, by talking about these cases, try to give you a sense of, firstly, what research ethics is, and then some of the ways, some of the places and types of questions that are currently topics in research ethics, and some questions you might want to ask yourself if you're either designing a study or you're being asked to recruit patients to a study. Obviously, I'm really happy to share these slides with you, so Aisha, maybe you can do that. And what I want to do, I'll come to you in a second, Mohit, and what I'll do is now is just want to talk about some very practical information. Yeah, go ahead. What's the question?
So my question is, and you talked about it a little bit in the chat. So we talked about like choosing locations based on certain factors that shouldn't be biased towards one group over the other, that are unnecessary to the scientific part of the research. So let's say, what if I was a researcher and I was based in the UK, and people's socioeconomics are usually higher, and so compensating them would use more money. Mm. So what if I do this research, let's say, like, as mentioned in the example, let's say Uganda, where the socioeconomics are not as high, and so the compensation would be lower. So would that be ethically wrong to do so? Because I don't want to pay more money. Let's say instead of compensating a person £2,000 for, let's say, attenuated malaria drug, I could just compensate an average Ugandan person like $10 maybe. Or £10.
What do you think?
Well, I'm personally, if I didn't have if I had enough money, if I was, let's say, rich, I would just like do it in the UK, let's say. But I don't have enough money, or I don't have that much money, and so basically these are people and these are people, and it's just a difference in pay, and I'd be able to do it otherwise, let's say.
Yeah, I do think there are a number of important questions here. So there's a question about compensation and what's an appropriate amount for that. There are questions too about are you doing research that's relevant to communities? So if you are doing research in low income settings, for example, to what extent is that research relevant? Seems an important question. That's not to say necessarily that it always should be. So it might be that people are willing and interested to be involved in studies that generate scientific knowledge for its own sake, for example. And then there are also questions about so that would be a good example. So the study I mentioned earlier, the malaria challenge study, this idea that people being given, as it were, a disease to study it. It used to be the view used to be that it was inappropriate to do that in a low income setting. That you should be doing it where the medical services are available to make sure that people are safe in those studies, and that and the structures in place to make sure they fully understand. So challenge studies, as a general rule, have been done in high income countries, so with medical students and so on. And then two sort of worries started to emerge. So one is, well, to what extent do those challenge studies done in high income settings really reflect the situations in which those vaccines or whatever are going to be used? So might and the immune system of someone who is living in an endemic malarial region, for example, be significantly different to that of someone who has never encountered malaria prior to the study. So there are sort of questions then about scientific questions about, if you really want to produce a good vaccine, maybe you should be doing challenge studies in endemic regions. And so that's now you're starting to see challenge studies done in, for example, I've had a bit of involvement in challenge studies in Kenya and Malawi. So you're starting to see that happen on the grounds that actually you're not going to benefit anyone unless you do it in the right population. But then that's raised these questions about fairness too, in terms of money. So people in Malawi are being paid a lot less to be involved in a challenge study than people who are in Oxford. So is that fair or isn't it? And of course it does raise these broader questions about resources as well. But yeah, lots of interesting things to talk about there. But given that I've only got about 3 minutes left, I will press on with my last few slides and then I'll stop. Is that okay, Aisha?
That's absolutely fine. Yeah, please.
Just take a couple more minutes. So I just wanted to finish with a bit of practical information, sort of, it's what you should do when thinking about doing a study. So what should you do when you're contemplating research? I mean, one of the key things in the Declaration of Helsinki, but it's become standard practice, is, if you're going to do a research project, then the procedure, the risks and so on need to be clearly formulated in a protocol, and the protocol needs to be considered by a research ethics committee. So that's written into the protocol. So one of the things is preparing for that. So this means research is almost inevitably going to require ethics of review from somewhere. There are some exceptions to that, but generally speaking, that's going to be the case. And there will be a question about, well, who for you, whatever institution you're working in, which is the ethics committee that's relevant. If you're doing a study in more than one country, for example, the Declaration of Helsinki requires you to get consent not only in the sponsor country, so your country if you're the researcher, but also in the host country. So if you were doing a study in Uganda, just to pick that last example, you'd get one in your own institution, and you'd also get ethics review in Uganda. There are a number of ways. So, obviously I don't know anything about the research ethics review structure in your settings, but it's highly likely that, institutions might have ethics committees. There might be other kind of committees associated with, so for example, in the UK, it's associated with the NHS, but that would obviously be different in different settings. So one question is, where do you go for your ethics committee? And you might know much better than I do. Then the second question is, well, what should be in that? What should you write in your research ethics form? And the focus mainly when research ethics committees are looking at research projects is usually on these three things. So one is, to what extent can we as an ethics committee be confident that valid consent is going to be obtained from the participants? Valid consent being, sometimes people refer to it as informed consent. In a way, that's a mistake, I think. Valid consent is informed is part of it, but it's also voluntary and competent, as I said earlier. Secondly, have you been clear about the harms and benefits that participants will encounter? Have those been managed, and are they appropriate? Can you justify them? And what are the potential benefits of the research for other people? So you need to be able to say something about that. And in most cases, they're not going to be a definitively right answer to each of these things, because they will pull in different directions. So the key thing is that you as a researcher in your protocol are able to explain what the risks are associated with your study and what the potential limitations are around consent. For example, that study at the very beginning in emergency settings, clearly consent's going to be an issue there. But you need to be able to argue nonetheless why the study is justified and what kind of protections are in place. And you're going to need to be able to defend those arguments under challenge. So when you're putting in a research proposal, you're very often being asked to do with sort of ethics, really. And then just final slide, I've mentioned some guidelines earlier. Here are some important ones. Clearly, there'll be others that are directly relevant to your setting. In the UK, we'd have things like Royal Colleges and various organisations associated with medical research that you would need to look at for guidance. But internationally, we've got the Declaration of Helsinki, which is kind of the founding document in some ways of medical research. But then CIOMS is much more focused on research being done internationally, so research being done in more than one country. And if you're interested in looking at kind of the origins, as it were, of research ethics, then you might want to take a look at the Belmont report, and there's a URL for that here. So I'll stop there. After this, I've got a few just cases I thought you might be interested in, some things to talk about. So I've left those in, and what I'll do is I will share these slides with you or with Aisha, and she can share them with, actually I already have them, so you feel free to share them with everyone. So thank you very much. I'll stop there.
Thank you very much, Professor Parker. That was a really interesting talk and gave us lots to contemplate on, and extremely informative. And we've had lots of comments in the chat as well.
Yeah, apologies, I couldn't see that while I was trying to talk and do, and I
No,
wasn't.
that's absolutely fine.
Yeah.
They were being brought up as people unmuted,
Yeah.
so it was really nice to see everybody engaging and enjoying and interacting. And lots of thank yous coming in.
Good.
For speaking to us. I know we've run slightly over time, but I don't know if you're happy to take questions for a couple of minutes.
I'm very happy. Yeah, I just didn't want to interrupt your timetable if you want. So firstly, I'm just want to say again, I'm really delighted you asked me to do this, and feel many of the same sentiments that Ian expressed at the end of his talk. So delighted to be speaking with you.
Great, thank you so much. So if anybody does have any questions, if you can pop them in the chat or raise your hand or unmute. And in terms of the sharing the slides, we have the conference booklet, which hopefully you've all had a copy of, and I can add it to the online version. Yeah, I press the smart button. We've got a raised hand, so.
Hi again. I ask a lot of questions, sorry.
All right. You're very chatty, but it's good. I need someone to talk to.
All right. So about the first case with the person of Alzheimer and about valid consent. So let's say the person was incompetent, but could you then refer to a guardian, let's say?
Sorry, I didn't hear that last bit.
If a person was incompetent,
Yeah.
like say they had Alzheimer's and they had memory loss, or maybe let's say they were in the ER and you had to use something really quickly and couldn't get their valid consent because they're incompetent, maybe unconscious or has memory loss. Well, then would it be valid to just like take the opinion from a guardian that, let's say, might not be under the same risks as the person who's taking the treatment, but they're the only person who can decide, and maybe they're moved by emotions due to the current crisis that their loved one,
Well, first of all, I suppose in some ways, you know, this is going to be, you might think about this differently if it was clinical practice. So let's say you've got as you say, you've got a patient who's got dementia, got Alzheimer's, there is some reason why they're lacking capacity, and that's going to be permanent. You know, so it's not a sort of part. If it was something, if someone lacked capacity for some reason that was short term, you might say, well, let's wait until they've got capacity again before we make this decision. You know, you might do something, but let's assume this is permanent. Then the question is, how would you make a decision about what to do, how to treat them medically? So that's one sort of setting, and then the other setting is a research study. You know, to what extent is it appropriate to include someone like that in a research study, and who should decide on that? And so certainly in the UK setting, and as I say, I can't speak for you, but there are laws around this. So there are certain rules, for example, around how you should think about the treatment side of things first, for example, rather than research. You know, so there's a I can't remember if it's 4 or 5 step process you have to go through by law. So the first is, can you do anything to enhance the capacity of this person? Can you do anything to improve their ability to understand? If you can't, you know, and that might be, as I said, you know, it might be weight, or it might be, you know, let's say they've lost capacity because of, you know, they're being sedated or something. You know, can you wait? Or if they're distressed, can you do something? So the first stage is sort of you know, can you do anything to enhance the capacity? The second, then, I might not get these in exactly the right order, but then is, you know, do you have any evidence of their prior wishes? You know, have they expressed a wish about what they would want to have happen in this situation? And there you might talk to relatives and say, well, you know, has he told his sister what he would want, or his mother, or his someone? And then there's other things in the UK, like we've got this thing called lasting power of attorney, you know, where you might be able to have nominated a relative to make decisions for you. And then the final point is, if you've got no evidence whatsoever, then you as a doctor have to act in the patient's best interest. And that raises all sorts of questions about what is the patient's best interest when his patient has Alzheimer's, for example, and you know what's going to be the right. You have no idea about what their wishes are. So, in the context of clinical practice, there are steps you go through. My personal view is, you know, the patients, but patient's best interest is the key thing in those situations. In the context of research, I think it's more complicated, because if we say we're never going to do research on people who lack capacity, then that means we're not necessarily going to learn anything about the treatment needs of people who lack capacity. So it must be acceptable sometimes to do research in those situations. I think the key thing there is going to be, firstly, to be able to make sure that the research has been commented on and appropriately judged by people, for example, involving patient groups, for example, or patient support groups in that kind of this discussion about the research. Secondly, getting appropriate oversight. And then thirdly, being very careful that the risks are managed. You shouldn't be in that kind of situation. It seems appropriate to say there should only be very minimal risk. That's it where, because people are not able to give consent. Anyway, sorry, Aisha, I'm going on. I'm talking too much. Maybe are there any more questions?
I can't see any more questions
Okay.
being sent on the chat, but thank you very much for staying and answering them.
You're welcome.
And just to address the rest of the audience participants who are still here, we've sent a feedback form in the chat, so please fill that in if you get the chance. And we're looking forward to seeing everybody tomorrow for the second day of our first conference. Thanks again to all of our speakers, and thank you very much to everybody else for participating.
Thanks very much. Bye.
Take care. Thank you.